as a physician researcher, is at the intersection between the Islamic tradition, biomedicine, and Muslim practices. On one hand, I study how Islam, right, as a value system, as a faith, as an identity, influences the ways in which Muslim patients engage with the healthcare system. And on the other side, I do work on how Islam informs the ways in which Muslim physicians interact with the healthcare system, so both clinicians and patients. But the other area of my work has to do with how fuqaha ulama, they think about Islam as a tradition from which to derive moral guidance to inform the behaviors and views of patients and clinicians. So my work is this in this way multidisciplinary, bringing together empirical, right, research with textual research and theological understandings. Alhamdulillah. So in the talk I present today, you're going to see a little bit piece of that, but I'm happy to discourse with you on any dimension of the work I present. So briefly, we're going to talk about patients and doctors at the beginning, the roles and purposes. Then I'm going to, the second part of the talk is going to be about models for the patient-doctor relationship. We're really going to talk about the ethical and practice implications of the various relationships. And then in the last part, some Islamic overlays, right? Some metaphysics and morality drawn from the tradition to help inform you. My understanding today is that most of the audience are medical students who, and so for you, as you develop your identity as a physician, one who has an Islamic identity but has a professional identity, this engagement between those two sides of your being is going to be very important. Right? We don't come into the healthcare environment and leave off our commitments outside of that, right? And so we'll talk about that at the end, inshallah. So let's start, in thinking about the meeting point of persons. As you see in these pictures here, you have two groups of individuals having a conversation. Uh, what changes between these people? You can imagine them as friends, you can imagine them as colleagues, you can imagine them as relatives of each other. What changes when though that conversation is not occurring in the social setting, but now in the setting of the healthcare environment? There's still a conversation happening, but what's happening now is that there are certain social roles that are being overlapped upon that conversation, right? That one individual is now inhabiting the patient role, and the other is acting out the doctoring role. So the conversation might still be about a quandary they have. So outside of the healthcare system, you might be talking about how you're feeling today, right? But when you're now in the healthcare system, when you're talking about how you're feeling today, you're now, as a patient, taking a certain kind of exploratory mechanism about that, and the physician is trying to understand and address that malady. So that's right. The conversations inside and outside are different because of those social roles. What is happening at a more sort of philosophical level is that there is a need being voiced by a patient that wants to elicit a response from the clinician, right? Or there is a concern being raised about something in their life, and what they would like is to have care provided by the physician, right? Or they're voicing their troubles, there's issues that they have, and they would like the physician, the clinician, to apply techniques and knowledge from the medical domain to address those troubles. Yet in that interaction, right, the patient is still reflecting what I would say is broadly speaking are community and social values, right? How they're living outside that informs the way they think about their malady, right? Their troubles. And the physician in that encounter is reflecting the medical culture. As you go through your many years of medical school, it is not hard to understand that you and have become then removed a bit from the community. You are becoming indoctrinated in a medical culture, right? Your education is indoctrinating you in a real way, making you think about different values than you might have prior to that training. So the patient is reflecting community values, and now the physician is reflecting or inflecting medical culture. So that communication can arise, and that encounter can arise with some challenges and conflicts because of that. Right? And we're going to go into this in a second. But at the end of the day, it is the patient doctor relationship, right? That's central to healthcare delivery. All of the benefits of healthcare come through that encounter for both parties, right? that relationship, just the relationship, I'm using that term really significantly. I'm not talking about the surgical procedure. I'm not talking about the knowledge that one has. I'm talking about the relationship between two individuals, the patient and the clinician. Enhanced trust in that relationship by both parties and better communication produces better outcomes, right? And it leads to more satisfied physicians. Meaning by giving importance to that relationship and building trust and having honest, transparent, and good communication skills leads to benefits for both the patient, meaning their health is improved, right? The things that we want them to do are more effectively done. And physicians themselves, right? The physician themselves in their profession, in their career, they're more satisfied. So it is critical to give that relationship this importance. The other aspect, I already mentioned that, right? Physicians and patients embody cultural values of their communities. Now, I mean the community of patients, the community outside, and the healthcare community. They're still coming at it from different lenses, right? But what needs to happen in an encounter is that you need to have joint advocacy for those healthcare needs for the patient to be furthered. We need to, in some ways, a mentor of mine would say, you need to activate the healthcare system to address the patient needs, and you need to activate the patient to take care of their health at the same time. We need to have that joint collaboration. So I can't underline, and my entire talk is built around this idea that that relationship is the basis of all benefits for both parties in the healthcare system. So we need to bridge build between those worldviews. So I know this is online and I'm not doing it in person, so we're not going to have the ability to dialogue as much. But but I want you to think about for a second, right, the relationship between doctors and diseases. What is that relationship? Have a thought in your mind. So often when I do this for medical students, they give me the metaphor of curing or healing or ameliorating. The doctors are there to cure disease. They're there to heal people who are suffering from disease or ameliorate the symptoms of disease. Another group of students often have this other metaphor that doctors are combating diseases, they're fighting diseases, they're terminating diseases, right? This sort of more warlike metaphor. But I want you to recognize that physicians also at times define disease, that we set up the boundary positions and when someone now becomes diseased. And not in all areas, perhaps, but there is this social and cultural construction of disease that occurs through the power of the physician. You're dysfunctional. So what might be a functional uh, mental health issue becomes dysfunctional, then we label that with disease. And that's a very important power to think about because you've become indoctrinated in medical culture and you apply that label. That's a big power, right? This person is no longer functioning. They need to be on medication for mental health issues. Or on a more social scale, people who don't have children, we call them childless. People who don't have children in the healthcare system that we say after 1 year of copulating in a marital relations, right? They're infertile. They become from a group that are childless couple to now an infertile couple. You have attached the label of a disease upon them. I want to talk about that in much more detail, but this is my point. That does a child who is born deaf have a disease? Right? Does a person who's not able to conceive a child have a disease? Does someone with unknown reason for short stature have a disease? When you in medicine and as medical professionals, you might label all these individuals as having diseases. But the communal values might say actually that's not a disease. There's a social and cultural construction of a disease. And that power leads to some responsibilities ethically to think about it. So I'm giving you a notion of that patient-doctor relationship is a very core importance. So let me just share with you a couple of ideas about disease. And I do this because I want to destabilize your notions in the beginning before I talk about interventions, right? So disease could be a dis-ease. Someone is not feeling well, and that is defined by the subject. So disease is not as simple as some biological thing in that case. It might be something other, right? It's being ill at ease. Or a disability, meaning someone has less than the normal, quote unquote, ability we think. That is defined by the subject, the individual, and society. You should be able to walk on two legs. If you're not able to do so, you're disabled. That's applying the label of disease or a disorder, right? So this is how we think the physiology of a certain organ should work. If it doesn't work that way, then you are disordered. You have a kidney disorder. You have a disease defined by the professionals, in this case, medical professionals or society, or dysfunction, which is defined by both. I should have this sort of functionality. My ears should be able to hear, but they don't. So in the collaboration between professional society, we say that then that's a disease of hearing. So the point of all of this is that this involves a truth claim by an individual about an abnormality or impairment or a deviation, and from some positive norm. Again, I'm giving you this idea because that leads to some power imbalances for the physician group. And for you medical students, whether you don't have, I don't I mean, Dr. Bushra told me you're getting some medical humanities. This is notions of sociology. Sorry, was that a question? Okay.
No, it was not a question. Sorry for that.
Okay. So I gave you the ideas about the power because we have to understand the power dynamics before we talk about the patient-doctor relationship, what it should look like, right? There is an authority and a knowledge imbalance that power lies within physicians. And as you have heard, right? And I don't know the Arabic saying, but in English we have the saying, right? With great power comes great responsibility, right? And so that's the idea that there's an ethical responsibility because of that power differential, right? That you must empower patients with knowledge and for informed decision making. So now moving to that's the context, to moving the second part of the talk, this is a paper by a classical paper, old paper in the Journal of American Medical Association, JAMA, but it really sets out the patient-doctor relationship in four models, right? And these are the four models, and I'm going to go through that to give you a sense to help you think about how we should pick the relationship that we want to have. As you form your identity as a professional, as a medical professional, you'll have to think about what model of that relationship you want to have, from paternalistic to deliberative. Okay. So let's start with the first one. The paternalistic model is a model for the patient-doctor relationship, again, the two parties of the clinician and the patient. That's a presumed expertise-driven model, right? That the physician knows best and the patient should follow, right? It's sort of that dictatorial idea. I've studied, I spent all this time, I understand, you should do what I want you to do, right? And the contextual usage for that is that this is used often and can be used legitimately in a justified way when there's high acuity and time pressure. I'm an emergency medicine physician, you heard. Often I know, do this, right? But this is also used when there's vast knowledge discrepancies between patients and physicians, when there's a huge discrepancy in understanding. And this is often termed the traditional model. Medicine used to be when physicians tell you what to do, you have to follow those orders, right? A prescriptive mode. The ethical problem with this is that there's limited respect for patient autonomy or the person itself. I mentioned at the beginning of my talk, the clinical encounter is the meeting between two patients, the two peer persons. The patient and the physician are persons first and foremost, right? So this is the ethical pitfall here, that if you have this model of paternalism, there's limited respect for the person who is the patient. That leads to decreased patient engagement and decision making, and the potential for distrust and decreased trust, sorry, and lack of adherence and not compliance, right? Because when you say patient compliance or lack of compliance, you're using the paternalistic model of I have an order you should follow, as opposed to adherence. Well, I gave them a recommendation. They chose not to follow that recommendation, right? It's a slight difference in nuance, but it moves you out of the paternalistic model. The second model is the informative model, right? And this, I will say, for many individuals who are becoming physicians today, particularly in the West, they seem to think of medicine in this sort of way. It's an information model, right? It's purely about information conveyance. Physicians provide information without judgment. You're asking for my expertise and knowledge. I'm going to deliver that to you. The benefit there is that you can prioritize the patient autonomous choice. You give them information, the patient chooses, they're making that choice. And the idea is that you can separate, or the benefit is separate medical facts from cultural values, right? The fact is that I have no cure for this disease. What we do is based on your choice, therefore, right? So there's this idea of a separation of fact and value and information sharing. The pitfalls and problems with this idea is that potentially it creates information overload for the patient and their family and the decision makers, and that means decisional paralysis. So much information is given without the backing and requisite literacy with that information that the patient could be paralyzed. And you often hear then, okay, well, doctor, what would you do? Or doctor, what would you do if this was your family member? Because of that information overload. It treats medicine as a mere field of knowledge and technical skills, which sociologically is not true. Medicine is not just about the facts of physiology or the skills of surgery. Medicine is a practice, right? And so this idea, this model treats medicine just as information, like a bot. Tomorrow, when Iraq has AI, you don't need physicians. All you need is a chat bot that's got all the information from the books you read, right? And give them some skills to have communication. That's sufficient as a physician. That's the model here in a hyperbolic way that is conveyed through this model. And effective communication also requires a balance between providing information and understanding where the patient can comprehend. Okay, so but this is the second model, the informative model. The third model of the patient-doctor relationship is the interpretive model, right? And this is the authors of that paper in 1992, two very well-known and authoritative authors, Ezekiel and Linda Emanuel. They say this is their preferred model, that it's a negotiation framework, right? That the relationship involves negotiation to align the differing moral values of the patient and the physician. So the idea is that you understand patient values and you help them interpret that of how those values align with their goal or with the goal in this clinical scenario. The benefit is that it leads to ethical symbiosis. You incorporate both parties' standpoints. You foster mutual respect and understanding. And then you're enhancing shared decision making, right? You're reinforcing trust, therefore enriching healthcare experiences. That's their preferred model. Now, the pitfalls of that model, it might require a lot of time and effort. And today, physicians are pressed for time, right? And it requires effort to elicit patient values and understand them and help interpret them vis-a-vis a clinical decision. Now, let me give you an example. The choice of chemotherapy and a regimen is a choice because some are more caustic, some are less caustic, some allow you to be in the hospital require you to be in the hospital through infusions, some you can do at home. You have to interpret the patient values to help recommend that, right? And they may be equally efficacious biologically, but the social setup might be different and may lead to different effectiveness. This is what I mean. It might require time and effort of eliciting those values, the cultural context, the social issues that might be at play. And it can be challenging when the patient and the physician have different values. So this doesn't ignore the fact that the physician has a value as well. This I don't think you should do, or this I don't think is the right thing to do. So when they are opposing, the patients and physicians opposing values, you might have a challenge. This becomes clear in the last model. So this is the deliberative model, which is my actual preferred model. And the authors of that paper, that classic paper, landmark paper, is their second choice model. Here it's really about shared decision making. You assume now at the outset that there are two moral agents, the physician and the patient. They engage in dialogue that's based on their values and they collaboratively make decisions. So an example that might be relevant here would be around controversial procedures, say around, you know, abortion, for example, right? Should you have an elective abortion because you have a fetus, right, who might have trisomy 18? So you engage then in dialogue here. Now, I'm not saying we'll talk about Islam and stuff later on, but I'm saying these are controversial procedures. Right? And the benefits, therefore, is that there is balanced interaction between both moral agents here, physician and the patient. The pitfall here, however, still is the fact that there's might be undue influence because of the physician's values and knowledge and expertise might overshadow the patient's values, right? Because there is a power dynamic. We can't ignore that. Just like I said, relabel what is disease and what is not disease. So my question for you, and now there's going to be a little bit of interaction for a second in your chat, is which model do you prefer as a physician and which model do you prefer as a patient? So here are the models. I want to just ask the group very briefly to just write down the number. The first number is the number that you prefer as a physician when you're the physician, and the second number being the one as a patient in the chat box. And this is also my check that I haven't put you all to sleep. It's evening there, it's midday here. So first number is what you prefer as a physician. Second number is what you prefer as a patient. I only have one response in chat.
I will talk to them in Arabic, maybe they will answer. طلابي بلكي تكتبون شو تفضلون يا طريقة. They have started to respond. Thank you very much. Yes, please respond. Which one that you like?
Okay, all right. So it seems, it seems that most people are in 2 or 3, but there's a lot more. It looks like there's more 2. All right, we'll talk about that, right? And this is what I suggested. I said that uh, today's learners think of themselves as just giving information, but that's a bit problematic. So I'll explain that to you in a second, right? That ideally the doctor-patient relationship has all of these components, right? That you have a shared beliefs, the physician brings compassion, their presence, the respect for each other, knowledge and experience, right? Integrity, that you have a full relationship. As I just mentioned to you, regardless of your knowledge and your skill set, the strength of that relationship, if they have a strong relationship with your patient, will lead to better outcomes for them and for you. I don't know how it is in Iraq, but we are suffering from an epidemic of burnout in physicians who are just too burdened by the amount of patients they have to see and the things they have to do, right?
The same in Iraq, the same.
Yeah, and part of that is if you have a stronger relationship, it's a better, more satisfying career for you, right? The information model, so the choice of these models, right, reflects an ethical choice. It betrays your vision of doctoring and speaks to your moral comportment, right? Ultimately, that then defines the expectations of the medical culture and expectations of society. If most of you believe that a physician should just be an information giver, as I mentioned to you, that when you now finish your residency training 10 years down the road, what prevents you from saying we should just have robots take care of patients? Robots can give better information than you can because they will be able to have uploaded all of the medical textbooks and the medical knowledge. Right? If we are simply information givers, then what is the point of doctoring? If we are just technicians, the Da Vinci robot does some better surgery than we can. And technologists will continue to make it, right? Just ChatGPT didn't exist a year and a half ago. I'm not saying it to save your profession. I'm saying to you that that fullness of what is the patient-doctor relationship, that doctoring is a human encounter could be lost if we simply think about the conveyance of information being the most important part or the only part of the clinical encounter. Right. Okay. So we can talk about that. I'll have some time, inshallah. I think I'm doing well on time. to have a further conversation, but I do want to engage with you because I want to understand what you're learning and your perspectives at that medical college. And we'll now shift to the last part of my talk before we get there. So I want you to think, or what is your vision of the good Muslim doctor? So we just talked about doctor-patient relationships. You shared with me that you think, most of you think that the informative model is a good model. Some of you say the interpretive model is a good model, right? And ultimately, you're going to decide what kind of physician you're going to be. Now, let's overlay Islam on top of that, right? What is your vision of being the good Muslim doctor? Before we came on, Dr. Bushra was saying, there's that sign that there was Hakim on the slide set. So I do have a nonprofit organization. This is the one. It's called Initiative on Islam and Medicine, right? And our tagline is to instill hikmah in healthcare, and our logo is the Hakim logo, in the sense that, right, this is obviously a name of Allah Subhanahu wa Taala, but we believe what is missing in healthcare is hikmah, is wisdom, right? That it is not human-centered enough, that we as physicians have foregone the idea, we've lost the idea that we are supposed to also be hakims, wise individuals, not just, right, ulama in this case, right, not just people who have knowledge, but wise people. So I want to say, when we think about religion and medicine here in the United States, at least, I don't know how it is at your medical college, they're separated, right? And people find it very difficult. And so when I say to you, what's your identity as a Muslim doctor? They say, oh, I should just leave my Muslimness outside the door when I enter the hospital. But in a very real way, religion and medical science both inform understandings of health, illness, healing, and cure. They do, right? What is health? What is saha? I'll share with you some hadith in a few minutes, but this is what I'm saying, that they inform what you think of health, illness, healing, and cure. They impact patient and healthcare seeking behaviors and their health behaviors, and they influence healthcare decisions, both medicine and religion. At a more fundamental level, both inform, right, and provide explanations for what's happening to you. Why am I sick today? Is that because of something I did? Allah subhanahu wa ta'ala has not given me health today because of something I did. People think that, right? And they answer the question of the human end. What happens to me after I die? Religion tells you something, but science says something too. You'll just dust, your material. There's nothing more to you. Religion might say there's a body and a soul. Science might say there's just a body. So both religion and science offer explanations for what's occurring, and both at times can have conflict because of the differing epistemic and ontological frameworks that they have. Those might be big terms. We don't need to get through them today. But now when I switch to the Islamic overlays on the patient-doctor relationship, I want you to understand that can be this sort of different view. What do I mean by that? Well, you and all know this, that we think as Muslims that, and I'll share a hadith in the Quranic ayat in a second, right? That everything comes from Allah subhanahu wa ta'ala. Both the disease and the cure and the outcome. That, everything is in the hands of Allah subhanahu wa ta'ala. And that we as human beings, yes, we have a mind, we have a body, we also have a soul. And that how we respond to that affliction, to that trial of disease or lack of health, how we respond to Allah subhanahu wa ta'ala, if that's through shukr and having the proper adab, then that will have some impact upon our disease illness trajectory. No one says ignore our healthcare, the hospital system, but primary importance to us is our adab towards Allah subhanahu wa ta'ala. That's for the patient, but the same thing can be said for the physician. And so let's go through that. Now, I want to give you a caveat. I know that I discussed this with Dr. Bushra. Aasim, right, myself, I come from a Sunni background. I did some studies at a madrasa. And so what I'm going to share today is with that inflection, but I do think it's generally relevant even for some of you who might be Shi'i or other backgrounds here. So let's look to, firstly, when you think about Islam, you always talk about our what does the Quran say? What does the Hadith say? And so I know there's different Hadith collections from the Imams and the Shi'i tradition, but this is from the Sunni lens. So please bear with me. But this is one that we have in Sahih Bukhari, right? About health, right? نعمتان مغبون فيهما كثير من الناس الصحة والفراغ, right? So the notion here that that health, صحة is a blessing, a ni'mah from Allah subhanahu wa ta'ala, right? Comes from Him, right? And then we have this idea, another hadith again, that it is going to be asked about. Allah subhanahu wa ta'ala, right? Will ask you about this. Alam nusahha laka jismak, right? That the first thing that is asked on the day of judgment, right? About the na'im again, about the benefits given, the blessings given to you, is about, did your body, did I not give your body health or wholeness? And then we know in another hadith here about the al-mu'min al-qawi khayrun habbu min al-mu'min al-da'if with good khayr, right? So that health, the strength that Allah is giving you is going to be accounted for, and that your ability to effect good works is better because have more strength, your bodily strength in this sense. So what does health then mean? That it is a grant from Allah subhanahu wa ta'ala and you're accountable for it. It's instrumental in value for doing good works and can be a characteristic of the body, but it's not fully reducible just to the body. That notion of health gives us our profession. Why is medical practice fard kifaya, right? It's because we help people increase their capacity to do good works by helping restore their health. Right? You follow? So our entire white coat profession comes through this idea of it becomes something that helps people regain their ability to do good works. Yet we recognize that, and this is from the Quran, right? Ibrahim alayhi salam, وَإِذَا مَرِضْتُ فَهُوَ يَشْفِينِ, right? That Allah subhanahu wa ta'ala is the one who cures. And this is again the hadith here from the Sunni canon. But manzalallahu dan illa anzalahu shifa'an, or the dan wa dawa'an, right? That Allah subhanahu wa ta'ala controls, He sends down and nazala, right? Disease and cure. So we recognize it's God-centric, right? That Allah subhanahu wa ta'ala is in control of these things. So when patients experience illness and when we attend to them when they're experiencing illness, we have to recognize, right, that we are, as some would say, we are in the conversation between the name Al-Muhyi and Al-Mumit. Allah is the one who maintains and gives life, and Allah is the one who causes death, right? So the person who's in the state of illness is in the state between the conversation between these two attributes of Allah subhanahu wa ta'ala. And we hope, and they hope, that his other attribute of being a Shafi comes about, that Shifa comes about, because Allah is the one who brings about healing. So the point of illness then is it's a humbling experience to direct one to Allah subhanahu wa ta'ala. It expiates your sins and can be a means of reward if you have the proper adab. And for patients, it's an opportunity for gratitude. If that's how we understand the patient-doctor encounter, that this individual is being drawn towards Allah subhanahu wa ta'ala through this temporary, hopefully, inshallah, issue with their body or their health, then we can help them, but we also have to understand our role as physicians then. Then the clinician is an audience with Allah subhanahu wa ta'ala. This is another hadith that we were told about, O son of Adam, did you not visit me if I was ill? If you had visited my servant, someone Fulan was ill, if you had went there, you would have found me with him. And we are serving as an instrument of Allah subhanahu wa ta'ala. There are other hadith about the prayer being elevated of people who are sick, like the prayer of angels. So we are in a very metaphysically important state where we are in audience with Allah subhanahu wa ta'ala in this sense by tending to the servant who is ill. What does that mean for us as physicians? Well, we have to recognize that we're an instrument of Allah subhanahu wa ta'ala to hopefully, by His leaves, with His idhn, to bring about shifa. And we have to strive hard to deliver the best care. This is another hadith in the Sunni canon, right? That إن الله كتب الإحسان على كل شيء. That we have to have ihsan here, right? أن تعبد الله كأنك تراه, right? That you have to have this idea that Allah subhanahu wa ta'ala is watching you, and that we should give hope and comfort to those who are sick, right? فنفسوا له في أجله. And the interesting idea is that, right, that the person has the appointed time, that Allah subhanahu wa ta'ala, right, is in control. But there are limits to that we are not supposed to do things that are outside our bars of practice, right? The one who doesn't know medicine or that part of medicine, right? That he is lawman, he's responsible for that. So we have to that's why you study and become licensed, so that you have this standard of practice behind you. and that you don't take life. And we won't discuss more of that. So this is the idea of the physician's responsibilities, right? Again, about that relationship, that we are now adding upon this layer, that we are an audience of Allah subhanahu wa ta'ala, understanding that our ability to affect change is through Allah subhanahu wa ta'ala's power, not ours. We also must recognize that us, medicine, is but one way by which to draw divine attention to the malady. There are other means of healing, right? We have hadith that tells us that giving sadaqah, that is a way to cure your sick, right? Or making dua itself is a way to get healing, right? Or amulets and other things as well. So my point is that we shouldn't overstep our bounds and say, no, medicine is the only thing. There are others. There are other ways to draw Allah subhanahu wa ta'ala's attention. He does not need us to bring about cure. And I'm sure you've heard about miraculous cures, right? By making dua, by doing some pilgrimage to places for, right? I mean, I know in the Shiite tradition, for some people, it is even having the mud of Karbala and other things they do. So my point only this is that there are ways to bring about healing, and we shouldn't ignore them. In the end, I'm going to close with this. I know we have a few minutes left. Alhamdulillah, I do want to engage if we can. But But for the Muslim physician, I asked you, what's your vision of the Muslim physician? I just gave you some ideas about the relationship. We have to understand that we have to be a complete individual in our ethics, right? So that Islamic bioethics here, and why those blue circles, it comes from, yes, we have to follow fiqh. Yes, we have to have some adab, right? Yes, we have to understand the theology of what's happening, what I just shared with you. And then we can be a practitioner of this, acting out Islamic bioethics. What do I mean here? Well, the act, right? Sharia tells us, right? Is this mubah? Is this not mubah? Right? Is this mandub? Is this wajib? Is this, right? That's the act. Sharia tells us, the fiqh tells us the act, right? But on top of that, you have adab, agent-based ethics. Yes, this is permissible, but how do I act? That comes from adab, right? And then on top of that, you have, what are we aiming for? What's the end goal here? Are we aligning our medical interventions with divine will, right? To address the spiritual malady. So you have to have act-based, agent-based, and end goal ethics, right? Meaning that what are we trying to accomplish? Are we trying to be conveyors of shifa? If we are, then how are we doing that? So in the end, I'll end with this idea, right? That the character of a good physician, now you can say a good Muslim physician, is that you have to have a compassionate comportment. You should exhibit compassion, view their role as both caregivers and instruments of Allah subhanahu wa ta'ala's grace as followed. You have to have trust. And what I mean by that is divine trust in Him being in control of all the outcomes of our patient encounters, right? And hoping that we ourselves are elevated through our practice. But we must respect the patient's body and health as an amana, as a trust that underscores both for the patient and the physician the God-human relationship. And we must be humble, right? Practicing humility fosters therapeutic alliance. We don't know everything. There are miracles. There are limits to our knowledge. Never everything is proven by, you can't even say anything is proven by double-blind randomized controlled trial, because the statistics that you use are about lack of randomness. They're not to prove something. For those who are doing that in the medical education, they know what I'm talking about. So we must be humble, and that enhances patients' trust and satisfaction with our encounters. I'll end with this. You heard in the bio that Dr. Bushra shared here that I'm part of a learning community navigation here at the Medical College of Wisconsin. And our medical curriculum is moving towards this model here, that aside from the technical craft and the knowledge, we want to inculcate within medical trainees, within medical students, a character, right? We want to form your characters, adab, right? That we want to have adab, and we want to manifest caring for patients. So the two trees of medical education are inculcating character and caring. That will then lead to, as you become more learned specialists, practical wisdom, prudence, when or not to do things, how to do things, right? Hikmah, and then that will lead to a flourishing society and a flourishing, both for the patients, the communities, and us as healthcare providers and the healthcare system in general. So with that, I will inshallah ta'ala end. Barakallahu fikum. I'm happy to take some questions and try to get through the material in time for us to interact. Jazakallah khair.